Our next speaker is a professor of surgery in New Orleans, which is impressive enough, but she's also the director of the Ochsner Neuroendocrine Tumor Clinic. Uh, you all probably know that as Nolanets. Dr. Waltering was the director before Dr. Maluccio. So at this point, I'd like to introduce Dr. Mary Maluccio and welcome.
Awesome, thank you. Thank you very much. And I really appreciate this opportunity to at least go over some of the surgical approaches to neuroendocrine. As he just said, I am chronologically old, but relatively new to neuroendocrine, having really gotten into neuroendocrine tumors around 8 or 9 years ago, and then took over the helm of the Nolanets program around a year and a half ago, and have been really pleased with it. So they asked me to cover some of the surgical approaches in primary and secondary neuroendocrine tumors. I also have no disclosures. So the objectives of the talk is that I want you to better understand what variables weigh most heavily into surgical decisions, the data that best supports surgery as a treatment option, explain how surgery is one of many treatment options that are not mutually exclusive, and to better understand morbidity, what it is and why does it matter. So when you're going in, or a new diagnosis, or something new coming up on a CT scan, from a surgical perspective, we're really looking at it as three main questions. Can all measurable disease be removed? Doesn't necessarily have to be just the primary, but that can we take out the primary with or without the metastatic disease and have all measurable disease be removed? What are the risks associated with the operation? And that has a lot to do with location, the extent of tumor burden in the organ site, and the potential for complications or morbidity associated with whatever procedure is going to be required. And then, do you have any other medical conditions or surgical history that would impact your ability to recover from the operation? So there will be cases where neuroendocrine patients have unique comorbid conditions, whether or not that be diabetes, malnutrition, short gut, whatever it is, where an operation may be possible, but that the ultimate downstream effect of the operation may be a trade-off of one problem for a different problem that then the patient would have to deal with over the course of their remaining lifetime. So there are also two important tumor-specific variables that go into how we recommend surgery. As the previous speaker just talked about, I won't go heavily into grade, but grade matters. So the grade of the tumor is based on the proliferation index, and that's that Ki-67 number. And we have the grade 1 to 3 that are still under a well-differentiated category, and then we have intermediate grade and then higher grade tumors. And surgery is less likely to be successful or impactful the higher the grade or the more aggressive the cancer. The differentiation status, which also goes into that whole mitotic rate that he just described to you, which goes into well-differentiated, moderately differentiated, or poorly differentiated. And surgery tends to hone the patients with well-differentiated, maybe some of the moderate differentiated, but less likely, not mutually exclusive, but less likely to be impactful in a poorly differentiated histopathologic subtype. So the lower grade, well-differentiated tumors have a more predictable biologic behavior, and therefore we can more easily and readily predict the outcomes if surgery is being considered. So definitions, when you are having a discussion with your provider about surgery. So there are really some important definitions to understand with respect to neuroendocrine. So when we talk about something being done with curative intent, that means that the procedure that is being described is meant to give you every opportunity to be quote unquote cured of that condition, meaning you would live without any evidence of disease. So we are diminishing to the extent that we can a neuroendocrine specific event over your remaining lifetime. When a surgery is being described with palliative intent, it does not mean it won't prolong life, but the goals of treatment are meant to alleviate symptoms related to the condition, to diminish side effects related to anticipated progression of disease in a certain site, tumor growth in some site, and where the success of the treatment is not measured in quantity, but in quality of life. So we do a lot of surgery in neuroendocrine with palliative intent, where the treatment is primarily to reduce symptoms or prevent symptoms related to growth. And then when surgery is being done with the goal of prolongation of life, it means that there's going to be evidence that even if we can't remove all of the disease, that by removing a certain component of the disease, it will be associated with a longer life than had we not done the operation. So the success of the procedure is associated with a longer expectation of survival compared to the procedure, compared to not having the procedure or medical therapy alone. So if you're having a conversation with a surgeon about where you fit, you could just take those definitions with you and they would be able to put that in perspective for you, even if they are not using these specific terms. So surgery done with curative intent comes in sort of two main categories. If you have local disease with no evidence of distant metastatic involvement, that would be like a mid-gut primary or a small bowel tumor, where you do a small bowel resection with a mesenteric lymph node dissection, you remove all measurable disease, and you are left without any evidence of disease after that operation. It could be a pancreas primary resection with a peripancreatic lymph node dissection, where, just like with the small bowel, there is no evidence of disease at the end of the procedure. And then in the lung, that would be a resection of the lung. We don't as often need the lymph node dissection in order to do it with curative intent, but that the lymph node dissection is based on preoperative imaging, but you are removing all measurable disease, leaving the patient NED at the end of the operation. Now, there will be cases where patients will have limited metastatic disease that can be completely removed. So a mid-gut primary with a single liver metastases can also be done with curative intent, although the surgeon will explain to you and the medical oncologist will explain to you that even if all measurable disease is removed and you are left NED at the end of the case, you are at above average risk of having a neuroendocrine specific event in the secondary site, maybe the liver. Or in mid-gut primaries, those are small bowel primaries that have lymph node basins that are deeper within the mesentery and or into the retroperitoneum. As long as we can clear all that disease, that's what our program has been most known for nationally, then ultimately it is just extensive local regional disease, but at the end of the case, you are left without any evidence of disease. Surgery that's done with palliative intent is when we are removing enough tumor burden to decrease symptoms of a neuroendocrine syndrome. That is most commonly employed with patients with carcinoid syndrome from a metastatic midgut to the liver. It could be removing tumors where the location is associated with pain. That could be removing mesenteric tumors that are causing ischemia or poor blood flow. And postprandial pain is when you have abdominal pain after you eat that is due to the fact that your intestine doesn't get enough blood flow when it needs it to digest the food that you just ate. And so just like ischemia elsewhere in your body where you don't get enough blood flow, it will manifest as pain. And it can be a very difficult problem, and one of which there's very little short of surgical resection that can keep that from getting worse over a patient's remaining lifetime. Large pancreatic tumors will also be associated with pain, whether or not that be back pain or pain related to a mass effect in that area, because the pancreas is tucked tightly into your back. There's not a whole lot of give in that area of your body. And then large liver tumors can also be associated with pain over on the right-hand side, or positional pain where resection of large metastatic lesions can palliate that pain or can prevent that symptom from getting worse, even if the tumor grows slowly over months to years of time. Tumors causing obstruction, that's bowel obstruction, bile duct obstruction, bronchial obstruction, anything where you can have even a small tumor burden causing a big problem just based on it being in an awkward location. And then tumors causing bleeding. It's most commonly intestinal bleeding, but it can be bronchial bleeding in lung carcinoid tumors, but that bleeding can obviously be a life-limiting problem, and therefore you would be doing that operation to either palliate that symptom of bleeding or prevent that symptom of developing. So surgery for prolongation of life is where it's kind of really important that the multidisciplinary team is in agreement with where surgery plays a role in any individual patient's situation. So surgical debulking, that's where that term surgical debulking is used most commonly, and that involves removal of the primary site. And the data on removing of the primary site has a lot to do with our not wanting that primary site to continue to seed metastatic tumors over time. But it also includes removing of the bulk, greater than 70% of the metastatic tumor burden. So although in most centers that do debulkings, we aim for far greater than 70%, but the data that has been published from a number of different neuroendocrine programs is that if you meet the treatment goal of greater than 70% removal of all measurable disease, that is associated with a prolongation in life compared to had we just used medical therapy alone. In order for then surgical debulking to be successful, we do need to know how much tumor we have and where it is. And that's where somatostatin receptor imaging comes into play, because it has helped us better understand the extent of disease and therefore better understand our ability to meet that 70% treatment goal. And then can we meet that treatment goal on any given situation? And then what is the individual risk, meaning the patient-specific risk, comorbid conditions, fatty liver disease, intestinal problems, heart disease, COPD. What are the individual risks that would potentially impact our ability to meet that treatment goal or get you through that operation with a meaningful future life? So when someone's talking to you about the risk of an operation, it is really looking at each individual patient, the specific variables in that situation that would put you at increased risk for having complications related to the procedure. And complications are the morbidity associated with that procedure that may be a trade-off of one problem for a different problem. And I'll go over some of those things when I go into the different types of operations that we do. So what type of operations do we do in neuroendocrine? So the small bowel and the colon anatomy are important for mid-gut primaries and colon primaries. So the small bowel is all this little squishy stuff all here. So your stomach goes into this first portion of your intestine called the duodenum. It goes in, and all this right here is called your small bowel. For neuroendocrine specific semantics, we call that mid-gut if it's in the small bowel. So this, when we're talking about the mesentery, we're talking about this area here where all the blood vessels are coming up into this small bowel. So the primary tumor is in the small bowel. The lymph nodes are in this mesentery, and the lymph node basins we're talking about are either first order lymph node basins where they're closest to the sausage right here, or you have mid-level lymph node basins, or you have deep mesenteric lymph node basins, or you have basins that are in the retroperitoneum, which is next to these big, important blood vessels. So the deeper they are, the tougher the case, and the deeper they are, the more difficult it is to render someone without any evidence of disease, because lymph nodes are like a spider web of trash cans that are trying to keep the tumor from spreading into deeper parts of your body. So how I describe this to the patients is like a fan, so that you have the small bowel sausage here, and the mesentery is like a fan, and the lymph nodes are within the fan. So a small bowel resection has to take out the primary as well as the lymph node basins. The colon is like a horseshoe right here. This is where the small bowel, the ileum, dumps into the right colon right here. And then the colon has its own mesentery exactly like this. It's just in this yellowy stuff. Same exact situation, lymph node basins. This is just the colon being lifted up so you can understand that the blood supply to the colon, very similar to the small bowel, comes along that same type of mesentery. So the types of surgery in the small bowel can be called a small bowel resection. So I'm going to start with this picture over here. This is the sausage. This is the mesentery. We need to take out the primary tumor that's within the sausage, and then you need to take out a pizza slice of the mesentery that includes all the lymph nodes that are going to be in that area. And then this is showing you that little pizza slice thing right here. We cut each section out, and then we push it back together so that now you've got two pieces of bowel that have been sewn together. The pizza slice comes together, and we sew this together. And this is just us testing that the opening is big enough for you to get food through there. The more common type of surgery that you will hear about with midgut primaries is a right hemicolectomy. That has to do with the fact that a lot of ileal neuroendocrine tumors or midgut tumors involve the ileum. And the closer this ileum gets to the right colon here, the more it shares a blood supply and the more it shares a lymph node draining basin, so that in order to render you without any evidence of residual disease within that area, you need to take not only that portion of the ileum, but you have to take that portion of the colon, because the pizza slice of the mesentery includes both those distributions. And then in a similar fashion to the small bowel resection, we just attach your small bowel up to the portion of your colon here. Excuse me. We call that an iliocolostomy. And some of the reasons why patients after that procedure will have problems with diarrhea is because you lose this very important valve here, ileocecal valve, that controls the flow of liquid getting into your colon. So pancreas anatomy is super important too. I describe the pancreas to patients like a fish. So you have the head of the fish, you have the neck of the fish, the body of the fish, and the tail of the fish. The head is like where you have the eyeballs of the fish. And what's important about pancreas anatomy is the fact that the head and the neck of the fish are lying in a portion of your body that has incredibly important real estate, making the morbidity, the potential complications related to that operation higher just based on the location compared to our being able to take the body or the tail of the fish. And I'll show you that in the next slide. This is just the lymph node basins of the pancreas. This is the head of the pancreas. It is tucked in here with the first portion of the intestine called the duodenum, and the head of the pancreas shares a blood supply with the duodenum, and therefore it is very difficult, I'm not saying impossible, very difficult to take the head of the fish without taking the duodenum. And then you take out these lymph nodes along with that specimen. That's called a peripancreatic lymph node dissection. So the types of pancreas surgeries that we do, the first one would be a distal pancreatectomy with or without a splenectomy, and I have two different pictures for that. So this is the tumor sitting within the tail of the pancreas, and you have cut the pancreas here with a margin there, but because of the location of the tumor relative to the blood vessels going to the spleen that are lying right behind the pancreas and are pretty much embedded within the posterior aspect of the pancreas, you have to take the spleen along with it, and then you oversew this portion of the pancreas so it doesn't leak pancreatic juice, and then you're left with a little bit of the body, the neck, and the head of the pancreas in its normal position, and therefore normal physiology. There are cases, especially in neuroendocrine, where the tumors are so well circumscribed that you do not have involvement of the splenic vessels, and you are able to take it exactly the same way over here, but you're able to peel it off of those vessels back there and leave the spleen in place. That's called a spleen-preserving distal pancreatectomy. The Whipple procedure is also called a pancreaticoduodenectomy. That is when the tumor is in the head of the fish or in the neck of the fish, close enough to the head where the blood supply and the peripancreatic lymph nodes are going to overlap. And therefore you have to take out the head, portion of the neck, this portion of the duodenum, and then this is where the stomach attaches on. So you end up taking out this whole portion. So this is the head, this is the bile duct going into the head, this is the portion of the duodenum, and you're left with three different things you've got to reattach. You've got to reattach the stomach, you've got to reattach the pancreas, and you've got to reattach the bile duct all onto your remaining intestine. So you bring your intestine up into a limb here, and then you sew the pancreas, the head of the pancreas, onto that loop of intestine, the bile duct onto that loop of intestine, and the stomach downstream onto that loop of intestine. So some of the some of the features of this case that give you a higher likelihood of having complications or morbidity or symptoms is the fact that we have to reconstruct you in these three different areas. And so some patients can have problems with this anastomosis and can have leaking of pancreatic juices. That's called a pancreatic fistula. But more commonly, patients will have a problem where the stomach attaches here and the bile that comes downstream here will reflux into the stomach, and that can be associated with some pain in your upper abdomen and a taste of bile sort of refluxing into your esophagus. That's called alkaline reflux disease. It usually will get better over time, but those are some of the things that people struggle with. So liver surgery, when we're talking about debulking, that includes liver resections. The liver is very much like a tree, and therefore everything that we do in the liver is kind of like a tree trimmer, trying to take out certain portions of the tree and saving the remaining branches. So you have the trunk of the tree coming in here. It comes up here and goes into the right and left half of your liver, and then each of those goes into different segments. So there are 4 individual segments on the right side, and there are 4 individual segments on the left side. And especially in neuroendocrine, we can take out individual sections, we can take out parts of sections, we can take out huge sections. The whole point is that we've got to take out that which is minimally required to get rid of the disease and leaves you with enough liver function and with little morbidity. So I'm using this as just an example where this is the tumor in the liver. This is the remaining liver of your in here, but that tumor, even though it looks like it's in a very awkward spot, is actually sitting in a pretty darn convenient spot if you think of being able to remove it just by coming along here and taking some of these small branches. It's actually really far away from both the trunk of the tree and the top of the liver that drains the liver up into your heart. So this is just what we see in the operating room. If we were to see those little things, this is exactly what NeuroN can look like. This is just a schematic of it. We don't take that much liver for that small a tumor, but you're pretty much just coming through and ligating all those small little blood vessels and literally, I call it melon scooping things out of the liver. This is just to show you how you can take larger sections of the liver that will incorporate multiple tumors as an option versus taking each of those tumors out individually. And it all has to do with location, but surgeons that do neuroendocrine type cases are really well versed in that which is required to get the disease out and leave as much liver behind. We call that parenchymal sparing or liver substance sparing surgery. So the lung, also like a tree, the airway comes in. This is your trachea. It goes into your right and your left bronchi and also goes up into different lobes of the lung on each side. And the interesting thing about, or I should say not so interesting thing, the challenging thing about neuroendocrines in the lung, they could be tiny little things like this little distal here that looks like this when you go down with a camera. And those can sometimes just be taken off almost like polyps or taken out of your colon. But that it can also be something like this where you have a much larger tumor that has grown and is obstructing the airway going into this section of the lung. causing complete collapse of this lung, where nothing short of taking out that entire lobe is actually going to render the patient without any evidence of residual disease. So these are just the type of lung surgeries that would be described for patients with lung carcinoid tumors. You can take a wedge resection, you just take a little section out, leaving the remainder of that lobe and the rest of the lung on that side. You can take out an entire lobe of the lung, this upper lobe, leaving the two lower lobes attached to that portion of the airway. And then there will be some circumstances where taking out an entire side, a pneumonectomy or entire lung is actually associated with a survival benefit. Not used very commonly, and I would always ask for a second opinion if that's what's being recommended. So not commonly employed, but definitely up there in the options that are there. So the treatment options, I think, is really important. Just like the previous speaker said, the treatment options are not mutually exclusive. So this is just a list of the treatment options that he went over. So I'm not going to go over again, but I go over it in a slightly different way that will help you understand how the expectations of how these will work in any given case. So surgery is one of many treatment options, and therefore no opinion is an adequate opinion unless you have gone over the advantages and disadvantages and why any particular case fits more or less into one area as opposed to the other, and that they will often be used either alone, but more often in combination. So for me, for those patients that are on that have ever seen me, is that I think this is just the clearest analogy for people, is that if you think about this disease a lot like cars or parking spaces, or you think about it like drug or treatment and receptors, then it's a little bit better or easier to understand what each of these treatments that we're describing to you is trying to do. So in neuroendocrine tumors, they have somatostatin receptors. Okay, that's what was previously described to you in the last talk. So unique to these cells are a receptor, and I call those the parking space. And whenever you have a trigger, you eat, you drink, you sleep, you jog, you will stimulate the neuroendocrine system. It will increase levels of neuroendocrine markers in your blood. And those are these little ligands, or these cars that are driving over your whole body looking for a parking space on these cells. These are the parking spaces. And when those chemicals park on those parking spaces or attach to those receptors, they signal the cell. And then I won't give you a quiz on this, at the end of the talk, but it stimulates a whole bunch of things that are going to lead to cell growth and or carcinoid syndrome. It's going to spew the stuff out that gives you symptoms. So the goals of treatment is to try to either clog the parking space so that it can't signal the cell, or get rid of parking spaces with either chemotherapy, radionuclide therapy, surgical resection, or chemoembolization. So that thing, your car parks onto this parking space, goes onto the receptor, it goes into the cell, and it has a certain effect. So when I tell people about then what we're trying to do with each of these different therapies, the one therapy that you have to kind of understand, because it is common among a lot of the different therapeutic approaches we use, meaning that we use somatostatin receptor inhibitors or somatostatin analogs in a lot of patients with neuroendocrine tumors. So what is that trying to do? How I describe it to people, it's like injecting you with a bunch of little cars. They're searching your body for these parking spaces that are on the net cell. And like a police officer putting a boot on that car, it's trying to keep that parking space from signaling the cell. And therefore, it's effectively inhibiting the cell from being able to spew out the stuff that gives you symptoms, and also trying to keep that cell from dividing. So you're trying to clog enough parking spaces so that when everything that you do that triggers your natural neuroendocrine system is that they won't be able to find enough parking spaces on those cells to cause cell growth. So somatostatin receptor inhibitor therapies are a standard of care for patients with somatostatin receptor positive neuroendocrine tumors, and they are meant to block the receptor so that the natural neuroendocrine system cannot then signal through that tumor cell. So as long as you have enough cars blocking enough parking spaces, that type of inhibitor therapy can be all that someone needs for many years, if not the remainder of their life. Now, this tumor cell, on the other hand, is going to spend its entire life trying to get around the boot on the car, either by generating more parking spaces so that then they will be able to get back to signaling the way that they want to signal. And then ultimately that leads to progression of disease. But what is surgical resection? Well, surgical resection is pretty much taking a big shovel and going out and removing entire neuroendocrine cells, and with that, a ton of parking spaces. So although it is the maximal invasive method of getting rid of parking spaces, it is highly effective at getting rid of parking spaces. And so when we talk about palliation of symptoms, when people have really bad symptoms related to a neuroendocrine syndrome, the reason why surgical debulking can help with those symptoms is because you can get rid of so many parking spaces in one operation that then the somatostatin receptor inhibitor therapy that you're on is more likely to be able to keep the remaining disease in check. Now, catheter-based liver-directed therapies are also trying to do something very similar. They're just going in through the artery that goes into the liver. And the reason why these work particularly well in neuroendocrine is because these cells are really dependent on the oxygen from the artery, and therefore you can selectively hit the tumor cells as opposed to the normal liver by going in and directing the therapy through the artery. So you put in these embolization particles, they clog the artery, they pretty much choke off the blood supply, tumor cells die, and with those tumor cells go a lot of parking spaces. So like surgical resection, catheter-based liver-directed therapies are also a very effective way for managing symptoms related to a neuroendocrine syndrome, but predominantly it's because it debulks, it decreases the total tumor burden within the liver, and therefore you are getting rid of enough parking spaces, whereby systemic therapy like somatostatin receptor inhibitor therapy is more likely to keep the remaining disease in check. So let's just look at surgery and survival. The strongest evidence to support surgery is going to be in G1, G2 midgut cases. So if you have a G1, G2 midgut case, even if it is metastatic, then at least some discussion about the role of surgery in that case is warranted. It's not to say that we never do it in G3s. It's never to say that we don't do it in higher grade tumors. It's just that the data that supports it, where there's a clear-cut survival advantage, is really going to be in highly selected patients with G1, G2 midgut cases. You have to be able to remove greater than 70% of the disease burden, and the metastatic sites are predominantly in the abdomen, although we have certainly debulked symptomatic nodes in the neck. So there's less robust, but not weak, it's just less robust data. There are plenty of papers out there on the use of it in metastatic pancreatic neuroendocrine tumor. It's just that requires a lot more discussion from the tumor board on the true benefits in any particular case. So don't be discouraged if someone doesn't jump into surgery resection if you have a metastatic pancreatic, but also don't hesitate to ask questions as to why or why it's not appropriate or when it would be appropriate over the course of the disease. So the reason why it is that the biologic behavior of pancreatic neuroendocrines is a little bit more variable, and therefore it is harder to predict the benefit. The surgery, as I described to you, comes with more morbidity, and therefore the investment, the physical investment to the patient is higher, and the patient selection is not standardized. Now, most of the papers out there have been limited to well-differentiated G1, D2 histopathologic variants. There is weaker evidence, meaning it would require a significant amount of tumor board discussion to use surgical debulking as a upfront or approach, or it would have to be the advantages and disadvantages compared to other treatments in the lung or bronchial net. That's because it's a rare of the rare in neuroendocrine, and therefore we just don't have enough series. But that there is definitely series out there. They're just single institution series out there and small patient populations, and it's just not the way that we really often make decisions in cancer based on small individual institution series. And so that just takes a lot more conversation. And then there's weak evidence. If any evidence, it's usually done with palliative intent to alleviate either pain, bleeding, or something in higher grade tumors. And that is predominantly because we just don't have enough evidence of benefit compared to other treatment options, systemic therapies, or clinical trials. So this is just a summary slide. I also will not test you on this. This is just a summary slide because if you get information about yours or your loved one's individual case and you want to sort of figure out where you sit in the algorithm that I've just described to you and what the previous speaker just described to you, that's what this slide would help you with. And then my advice to people, okay? And I think that you're going to get this like this beaten down over the course of the conference, is that treatment plans in neuroendocrine need multidisciplinary input, meaning that a really solid program has all components of the team with equal value and an equal voice at the table. You need surgical oncology, medical oncology, radiation oncology, which is a critical component of all cancer programs. In this disease, it's mostly the nuclear medicine guys that are there because they're the PRRT people, but in some programs that may be the radiation oncologists. And then you need the interventional radiologists because they're the ablative and the catheter-based techniques. And the program must function with all disciplines giving independent recommendations. Then you need a tumor board summary, and there has to be a consensus because each treatment plan has to be individualized to the patient. I firmly believe, not just because I'm a surgeon, but that the recommendation for or against surgical intervention needs to come from a surgeon. So when in doubt, if you're getting it from it does not mean that they aren't functioning with a perfectly fine tumor board. It's just that surgeons have a way of describing things that are very technical oriented. And as long as you understand from the earlier slides what the treatment goal is, you would be able to have a very educated conversation with the surgeon. But it's difficult for a medical oncologist to talk about surgical stuff just as much as it's hard for a surgical oncologist to talk about some of the side effects of chemotherapy. The treatment can be used alone or in combination, but I never want people to think that it's mutually exclusive, like you're running out of options. So that sometimes we will use them alone, sometimes we will use them in combination, but that at the end of the day, if you develop progression of disease, it's almost like all of those treatment options will then go back onto the plate, and we will look at the pros and cons of each of those in that particular case. Now, because neuroendocrine patients will live a long time, treatment must be used judiciously. You can't throw the whole kitchen sink in at the beginning, even if you're the most proactive patient, kick it in the butt, get it all out of there, whatever, is that in neuroendocrine, you have to play the long game. So the goal is to keep treatment options open, even if that means you have to live with some burden of disease over many years of your life. Don't hesitate to ask questions about what factors go into the treatment recommendations, and then keep copies of your records, because as I said, you could get a second opinion with just having the basic information about the pathology that shows us the grade, the operative reports that shows us what went on if you had been operated on for the primary site, the imaging and clinic notes, so that we can put other opinions in perspective for you. Okay, and for most neuroendocrine specific subspecialty programs, the virtual platform has allowed us to give second opinions almost nationwide. There are some places where it's tough, like California, maybe New York, but that we can always give second opinions. So it is, even if we're giving you the exact same opinion as you're getting closer to home, when you hear the same words come out of two people's mouths, then you feel more comfortable with the treatment plan, even if it's not as aggressive, or it's not as optimistic, or if you're disappointed that they can't do more. Is as long as it's coming from the mouth of two different individuals that may be describing it to you in slightly different ways, it gives you more confidence that you're getting the standard treatment for what is a rare condition. These are all of my contact informations. If you ever want a second opinion from our clinic, and that as long as you just gather all of that information, like you have a little bit of binder of all of your information, it's actually pretty darn easy for us to give a second opinion just based on that information and imaging. So with that, I'll stop, and I'm more than happy to answer any questions.